I'm Dr. Daniel Griffin.
And I'm Dixon DePommier.
And today we're going to be discussing the common complaint of ear pain.
Ear pain.
All right.
You're going to hear some anecdotes here from moi.
Should we start with anecdotes?
No.
Okay, let me give just sort of a little introduction, and then I want to hear the anecdotes. I love stories.
You got it.
And so when we're talking about ear pain, we're often worried about infections.
Yes.
Not always, but broadly that's going to be a major concern. And we're worried about infections. We roughly break it into external and we'll say deeper infections.
Right.
Okay. But you have an anecdote.
I do. I have several.
Okay. Let's start with the anecdotes.
The anecdotes are as follows. So as a child, I had the privilege of growing up. I was born in New Orleans, but I didn't grow up in New Orleans. But my grandparents lived in New Orleans, so I would vacation back in New Orleans with them for maybe the age of 4 through 7 or 8, maybe I can remember up to 9. And of course, New Orleans is in the Bayou country, basically, but it's northern Bayou.
What does Bayou mean? What is Bayou? Is that swamp country? Is Bayou like a word for swamp?
It's another name for the delta region of the Mississippi River, basically.
Okay.
That's what it is. And it's a series of interlaced, interconnected canals that the river has carved through on the way to the ocean. So fresh water versus salt water and swimming as a child, growing up knowing how to swim. I knew how to swim by the age of 6 or 7. I'm not gonna make this a long anecdote, by the way. And swimming in fresh water, not a problem. Swimming in salt water, big problem. What was the problem? But the problem was that one of my ears, and I can't remember which one it was, would not clear the water out of my ear. And it would sit there. And the salt water would foster the growth of organisms which would cause me to suffer from pain. And we would go to a doctor, and they would clear out the ear, and out comes the fluid. No blood or anything, but it was it was the outer ear, but very close to the eardrum itself. And that was chronic for me, and I became chronically aware of the fact that if I didn't swim in salt water, I was okay, and so I would avoid it. And then as an adult, I tried to get certified for scuba diving. And it just didn't work out. It just did not work out. During my initial dive in the Grand Cayman Islands, trying to certify at a depth of 60 feet, I got to the 30-foot mark, and the pain was so intense in my left ear that we had to go back up.
Oh, interesting.
And I never did qualify.
Okay. Well, your anecdote, your story is super helpful because it brings up several points that I want to be able to discuss today.
Good.
And so the first we'll talk about is the distinction between, as we brought up, outer, external ear infections and deeper or otitis media infections.
Right.
And what you're describing is actually the classic otitis externa, which is an infection of the outer ear canal, which often is associated with water being left in the ear. And the water, much like when we've been in the tub or we've been in the water too long and our skin starts to change, the canal can start to get, we'll use the word macerated. It can become inflamed, it can become irritated, and you can have increased bacterial growth.
Stasis, so they accumulate and then they start to grow.
Exactly. You're basically sitting there in this wet, moist, dark environment, everything you want to grow your bacteria. And this is quite common in children because they're often in the water. The head is often under the water. The otitis externa is really a warm weather, water-associated infection, and it's associated with certain pathogens, certain bacteria that thrive in that sort of environment, including Pseudomonas.
A soil dweller.
Soil dweller, yes, but also outer ear infection dweller. So that's one of the. Now the middle ear infections are often going to be caused by different bacteria.
Those are different, right?
And those are going to be a little bit more of a challenge because the outer ear infections are often very obvious. You can look and see right there. But the middle ear infections are going to require your ability to visualize the tympanic membrane. So this is a situation where you're actually going to require a little bit of technology. You're going to require an otoscope, something that allows you to actually to visualize the eardrum.
Right.
And often it can be hard to visualize the eardrum because there's something called cerumen.
Indeed.
We'll talk more about cerumen.
You're waxing philosophical.
Yes, we will wax about what to do about cerumen. But that can be a challenge when someone comes in with ear pain and you're trying to distinguish an otitis externa, an outer ear infection, versus middle. One of the issues might be when you pull on the ear.
Yes.
A middle ear infection usually is not associated with much pain, while an outer ear infection, when you pull on the ear, incredibly painful. My son Barnaby recently had an external ear infection, again, associated with spending lots of time in the water, the water sitting in the ear. It wasn't prevented. There's a lot of drops now that have like an alcohol, vinegar, things like that, that help evaporate, help dry out the ear, decreasing the risk. But often if you've got all that macerated out, you don't have to look very far before you can see all the red, irritated ear.
Poor guy.
And then the otitis media, you're going to have to visualize past all that and look at the eardrum. And the eardrum will often be red. You might see fluid behind the eardrum. Pediatricians will actually use often a bulb to see if the eardrum moves in and out. A crying child, often the eardrum will appear red. So somehow it's ideal if you can look in the ear without making the child cry. It's a special skill.
Good luck.
And then the distinction between these two types of acute, there's also chronic. You mentioned your problem was chronic. Was it that you kept getting infections or you had an infection and never went away?
No, I kept going. Well, I didn't go in the water that often afterwards because it hurt. So I would avoid it, and that's probably why I became a skilled fisherman.
You keep your head out of the water.
Yeah, exactly. So the other thing I think that I personally have is an overproduction of cerumen, at least during a certain period of my life, where I used to have my ears cleared out routinely by visits to the local physician. Whereas that problem has seemed to abate it.
Yeah, so we'll finish off with what we mean by chronic, and then we're actually going to give you a little bit of advice that maybe about cerumen issues. So when we talk about a chronic infection, this means greater than 2 weeks of a persistent infection. So if you keep getting infections over and over again because you keep going in the water, you keep having, then that's recurrent. If the infection lasts more than 2 weeks, particularly the middle ear infection, this can actually spread to the mastoid bone. You can get what we call a chronic suppurative otitis media. And that can actually be quite devastating if not recognized and treated early. But you bring up cerumen. A lot of our challenges in visualizing might be thwarted by earwax.
This is true.
And I feel like sometimes a lot of primary care docs they're spending a lot of time washing out that outer ear, right?
I used to go to the pediatric clinic, and I had a good friend there, and he says, "Okay, come on in," and he'd sit down and he'd scoop out all this cerumen. There's no other word for it except that. And he was a good man.
We could use the earwax.
We could use earwax. But then he became a good friend of mine, and routinely during my early years of teaching at Columbia, I didn't know what to do because I didn't know anyone there. And then all of a sudden I met this individual, and he and I became very close.
He was like your barber, right? Every 2 weeks he would clean out your ears.
More than that. It was like every 6 months or something of that sort. I would reward him by making CDs of various groups of animals that he would then take home and share with his children. So I did one on praying mantises, and I did one on spiders, and I did another one on, I didn't do the yucky stuff like parasites. I did gentle things, and the nudibranchs, that's another thing. I did. So we had a thing going for a while.
So I worry that if I give you advice on how to cure your earwax, that this relationship will be
Oh, Daniel, you
But
have
I'm gonna
so
give
many
you
more
advice anyway.
things to give me. And where would we start?
So let's talk a little bit about what we can do. So earwax is a problem not only as an issue of ear pain, but it can be an issue with hearing. People may have and this is going to be a problem particularly in older populations. It can be a particular problem in drier climates where the earwax is constantly developing and it becomes dry and actually obstructing. A lot of seniors have challenges interacting because they can't hear.
Exactly.
And so that is one approach. You can periodically go to see a clinician and they can dig it out mechanically. They could use a device where they wash it out, they irrigate the ear.
I used to like that. I actually, that was quite relieving, and I was amazed at how much stuff actually came out. I mean, like you could measure in pounds almost.
Yes.
It was quite. How long is that canal? I mean, where does it go?
It's actually it's longer than people think.
It's very long, and it surprises all the patients to say that came out of my ear. And by the way, please don't talk so loud.
Now, you can buy an expensive little bottle at a lot of pharmacies that you pour in and it gets the wax out and has catchy names. Or what do we do? What do I recommend? Now, what I'll recommend to people, and I actually, a lot of my older patients, I'll say do this on a regular basis, is get one of these little dispenser bottles and put a towel over your pillow. And before you go to bed, you'll lay down with the ear that's bothering you and you'll fill the ear canal with oil.
Oil?
And what sort of oil? Olive oil?
Really?
Corn, cooking oil?
Extra virgin or regular?
I think the extra virgin is the best. No, it doesn't actually. It could be canola oil, it could be corn oil, it could be olive oil.
Oil?
And what that will do is the earwax will be brought into solution, and in the night, when you roll over, that's why, of course, we want to have our towel.
I love that.
And if you do that on each ear, and you do that every, say month or two, it will keep the ears nice and clear. And it will help prevent problems with hearing.
Wow.
And often when we're treating someone who has an otitis externa, not only are we going to be putting eardrops in there, but there'll be an increased production of the cerumen. So you may actually do a little bit of oil to help dissolve, to clear that out, to help clear out the ear.
What happened to the hydrogen peroxide treatment?
There's
a little harsh.
Well, that's what I worry about. It's a little harsh, particularly in an ear that's irritated. So there used to be this common practice in the United States where people would mix vinegar and hydrogen peroxide, and you get a little basin and a syringe, right, and it would wash out the ear.
I'm afraid with my ear and my brain, you'll squirt it in this one and it'll come out this ear.
Yeah, I'm not a big fan of
But
some of the after ear remedies where people are swimming, they want to drown, will actually have a little bit of alcohol, isopropyl alcohol, where they're putting a few drops in, and that'll mix with the water and it'll actually allow it to evaporate and dry. That's great preventive, but once you've got an irritated, fired, infected external ear, not exactly so great to pour gasoline on the fire, alcohol on the irritated.
I hear you, sure. No, that's a wonderful not so home remedy.
Exactly. So let's reiterate our diagnosis. So we're trying to make a distinction between acute external ear infections, ear canal infections, acute otitis media, and then our chronic forms of these.
Right.
So the acute otitis media, we're going to want to be able to visualize that eardrum, the tympanic membrane, and see if we see fluid or infection there. The external ear canal, we're going to be able to see inflamed, irritated pain on pulling on the pinna or the ear. And then treatment is going to actually be dictated by the type of infection we see or do not see. If we see acute otitis externa, some people will actually use ear wicks. And they'll actually take a small earwick and they'll actually use that, they're trying to dry it out. Maybe they'll use the olive oil to get the cerumen out of there. Wow. There are some ways to do that.
Yeah.
If it's severe enough that you need to, we'll often use eardrops that have a combination of an antibiotic and an anti-inflammatory agent.
Got it.
Both targeting the Pseudomonas, which is often involved, but also calming down the fiery inflammation.
Right.
But a big part of this is drying it out, is getting the cerumen out of there,
That's right.
and allowing the ear to be dry and all the fired up.
So what about the inner ear?
Now the inner ear is a little more challenging. In certain parts of the world, in the Scandinavian countries, they don't treat. They let it self-resolve. And what will often happen is the pressure will get to the point where it's incredibly painful, the tympanic vein will rupture, and the infection will naturally resolve itself.
Oof.
Now, in many parts of the world,
That sounds a little heroic.
in many parts of the world, and that's an effort to try to decrease the risk of antibiotic resistance. And 99 times out of 1,000, that will work. It will resolve itself. And there will be that experience of intense pain, and now it's better. And when they come to the clinician at that point, some clinicians will just let it take its course. But there is that 1 in 1,000 chance that the middle ear infection will spread, will end up in the mastoid bone, will end up maybe as a meningitis. So we have a bunch of recommendations. So for those people who are watching, you'll see the recommendations now. But for those of you listening, much like our talk on the urinary tract infections, a lot of the country guidelines and the World Health Organization recommendations involve using higher dose amoxicillin. And they'll be weight-based for the younger children. As you get to adults, you're going to be using amoxicillin, maybe 1,000 milligrams 3 times a day for about a week. So a pretty high dose. Wow. Previously, we used to use something called Augmentin, which some people often use, which is an amoxicillin clavulanic acid. It's an amoxicillin and a beta-lactamase inhibitor. But what we found is by just using a very high dose of amoxicillin, we can avoid a lot of the stomach, the GI, gastrointestinal distress, and get the same efficacy.
Right. But I was actually concerned about the cochlea itself and the cochlear fluid. Is there ever an infection of the cochlear fluid?
I would say very rare, not something we're going to see commonly.
Okay. But if that should happen, wouldn't that create a balance problem in the patient?
Well, a lot of times when people have a middle ear infection, they will have issues with vestibular function. And they'll feel vertigo, they'll feel nauseated.
And that's the complaint that would lead them to the clinic.
And that might. Usually the overwhelming is the pain. And when you have a middle ear infection or an outer infection, incredibly sensitive, incredibly painful.
No, I couldn't get below 30 feet with my scuba. I was perfectly happy swimming in 10 feet of water. Perfectly. I mean, I took about 3 months worth of diving lessons in a pool.
And then you were?
Yeah, and then, then I knew that I had this problem. So a lot of people believe me when I tell you this. They become certified for scuba diving by taking Sudafed.
Oh, interesting.
They take it 2 hours before they go to dive because they say that they want to create as much open tubular connection between the eustachian tubes and the middle ear as they can possibly create. Because if you get down below 40 feet and the ear closes, now you have a reverse block. And as you come up, that block begins to place pressure on the inner ear, and they claim there's no pain greater than that, and you can blow out and lose an ear, basically like this. So everybody that I talked to took Sudafed or some derivative of an anti-inflammatory to prevent, or is that a steroidal?
So Sudafed is actually a vasoconstricting medicine.
And
what it does is by vasoconstricting, it's going to open up your sinus passageways. It's also going to open up the eustachian tube that connects the middle ear to the mouth.
That's what
that's what people are doing when they're maybe taking up in altitude.
Yes.
And they're getting changes. They might actually hold the nose and blow. And what you're doing is
called a Valsalvo, by the way.
Sort of.
Sort of? What is it called?
So the Valsalvo is bearing down. This is actually just blowing against a closed nose.
I see.
But what they're doing is actually moving air pressure through the mouth, through the eustachian tube into or in the inner ear. But yeah, I think that story reinforces how incredibly sensitive the structures in the middle ear are. So people coming with ear pain, whether you treat them or not, they're often in exquisite pain. And so it's an acute situation.
Great.
All right.
Yep.
Well, thank you for joining us for our discussion of ear pain, otitis media, otitis externa, both acute and chronic, and we look forward to more conversations.